We appreciate Katie Spear, who's presenting this topic on the consideration supporting the current KC standard of care. And Katie will go over three areas that provide legal perspective related to the possible risk involved in KC patient life cycle, such as failure to detect, failure to refer, and referring to users of unapproved devices. So I'll let Katie get up here or stay down there and do her thing. So we appreciate it. Thank you.
I'm going to stay down here unless anybody objects. Can everybody hear me okay? Can you hear me in the back? Okay. All right. Well, y'all go ahead and continue eating. You're not going to bother me. The food looks delicious, though. I'd love to have some caprese salad. I'll tell you a little bit about me before I get started. I am an optometrist. I practice in Pensacola, Florida. I've practiced there for almost 20 years. I have a multi-location practice with employed doctors, staff. We do kind of your bread and butter primary care optometry. I'm also a healthcare attorney. I went back to law school in 2015 and did a dual certificate program in health law and compliance. So I do practice law in Florida and other states as well too. So I have a few housekeeping slides that I've got to get through before we can actually start the meat of the program, okay? So bear with me. I actually have to read most of this slide, so I apologize ahead of time. So we're here today to talk about eye-link corneal cross-linking. Indications for this is Photrexa viscus and Photrexa are indicated for use with the KXL system in corneal collagen cross-linking for the treatment of progressive keratoconus and corneal ectasia following refractive surgery. Important safety information. Corneal cross-linking should not be performed on pregnant women. Ulcerative keratitis can occur, and patients should be monitored for resolution of epithelial defects. The most common ocular adverse reaction was corneal opacity. Other side effects can be punctate keratitis, corneal striae, dry eye, corneal epithelial defect, eye pain, light sensitivity, reduced visual acuity, and blurred vision. Does that sound like a commercial? I do, don't I? These are not all the side effects that could occur, so I encourage you to visit this website here, labelwithkeratoconus.com, and you can actually see the label itself. I know you all care about it. Read it. Yay, we're done. Other disclosure slide. I am an attorney, but nothing I say to do today should be construed as legal advice, okay? If you've got legal questions, then reach out to your attorney, all right? Okay, done with the housekeeping. I am super excited to be here today to talk to you about a new era in management of keratoconic patients. We know keratoconus is a progressive eye disease. We all know that. What you may not know is that 70% of keratoconic patients actually present through our optometry offices. We are the primary eye care providers, and 70% of patients with keratoconus actually come to us first. Therefore, it's really important for us who are on the front lines to be able to diagnose these patients and diagnose them early enough to prevent some of this progression. If we do that, sorry, this is a build slide. I'm going to keep going. Diagnosing patients with keratoconus early and getting the proper treatment protects patients, but it also protects us. If we look at the studies, we see that about 7 to 17 malpractice claims are filed per 100 doctors every year. Now, this is not just optometrists. Our malpractice rates are pretty low. This is all physicians. However, you don't want to be one of these. You never want to be one of these. And my intent today is not to scare you at all. It is to educate you. Because what you'll see is if we do the right thing for us, it's usually the right thing for the patient as well too. So today is all about educating you on new treatments for keratoconus so that you can ensure that you're, one, diagnosing them early enough, and two, referring them when necessary. These are the topics that we're going to talk about today. It's just the legal implications around keratoconus and the new standard of treatment. First, we're going to talk about the failure to diagnose. So, keratoconus, we know, is a progressive disease. It's pretty common. I think we all have seen it before, right? We see it multiple times in our career. It's not like it's very rare. And one study found that patients, even though we have incredible new technology in our practices, in fact, let me stop right there. How many of you have topographers? How many of you have tomographers? How many of you have an autorefract that has K readings, right? Everybody, right? And we all have that, okay? So even with all of this technology, and the technology is incredible today, we're still missing these patients. In this study, only 13% of patients were diagnosed before the age of 18. But we know that keratoconus doesn't come on all the time after 18, right? I mean, it may get progressively worse after 18, but there are patients that need to be diagnosed before the age of 18. I'm sorry, do I need to turn it down? Are you good? Okay. And in the same study, 70% had reached stage 2 of keratoconus progression before they were diagnosed. This is a miss because we are the primary eye care providers, so we need to be diagnosing these patients and diagnosing them early. Why is it so important to diagnose them early? Aren't we just going to slap a contact on them and see if the vision gets better? No. The reason that it's important is because the standard of care for treating keratoconus is changing. The reason it's changing is because we have a new treatment that shows that we can slow or halt the progression of keratoconus for these patients. So just like you would with glaucoma or any other progressive eye disease, we have to manage these patients accordingly. We have to actually diagnose them early and then get them the proper treatment so that they don't progress. So I said something about standard of care. I want to take a minute and dive into that just high level. Standard of care is, I'm sure you've all heard about it because we all had those classes in optometry school. Standard of care is a jurisdictional issue, which means that the definition is defined by where you live. Okay? So depends on the state, depends on the area of the state. However, if a malpractice claim actually gets to the court system and the court is determining what is the standard of care, they will use jurisdiction. But a lot of times they like to use published guidelines. And so if we look at AOA, if AOA has a published guideline on how to treat something, or the American Academy of Optometry has a published guideline on how to treat a disease, the courts are going to look at that to say, okay, was this physician following that standard? It becomes part of the standard of care. And I told you that, or maybe I didn't, but in 2016 is when iLink was actually FDA approved, okay, for corneal cross-linking. In 2018, the AAO, the American Academy of Ophthalmology, actually changed their preferred practice patterns, their guidelines, and I don't know how many of you use those, but I use them all the time with different diseases because I like to make sure whatever my treatment is that I'm doing the right thing. They changed their guidelines in 2018, so about 4 years ago, and they changed it to say that when we see keratoconus patients with keratoconus progressing, we need to refer that patient for corneal cross-linking earlier rather than later, because the cross-linking actually prevents or halts the progression. So that's why standard of care is, or standard of care and treatment is so important. We know it's a progressive disease. 1 in 5 patients who are not treated may end up with a corneal transplant. So we have treatment. We know the treatment works, and it works better the earlier the patient gets it. So that's why we're talking about this today. Failure to diagnose is the most common claim, malpractice claim against optometrists. about 55% of malpractice claims encompass failure to diagnose. So with keratoconus, some misdiagnoses may just be simple astigmatism. It may be dry eye or amblyopia. You think these patients, may not have keratoconus, they may have one of these other diagnoses. It's important. So how do we prevent misdiagnosing or not diagnosing a patient with keratoconus? Well, have a process, and you're going to hear me repeat that like all the time. And people in here that know me know that I have a process for everything in my office, because I like to make sure that every patient gets the same treatment every single time with every doctor in the practice, especially when you have different doctors in the practice. Not everybody does the same thing the same way, right? So especially when it comes to referrals or diagnosing patients and treatment, I like to make sure that we have a standardized process. So if you've got the equipment, we all have the equipment. We all have the right equipment to diagnose keratoconus patients. Even if you don't have a topographer or a tomographer, you can still diagnose these patients with autorefractor and with case, and that's standard. This is a very interesting study. It was done by one of the big malpractice carriers, and they surveyed closed ophthalmology claims. So this is specific to ophthalmology. They looked at those closed claims, and they found that the failure to timely diagnose patients wasn't actually because the doctors didn't know how to diagnose it, or they didn't have, the clinical expertise to diagnose it. It was really a breakdown in communication within the office, between staff, or between the office and patients. So how do you mitigate this risk? It's by having a process. So for example, if you do, in our office, we do topographies on every single patient. Okay, it's part of the workup process. So, if I do that on every single patient and one patient shows that they may have keratoconus, but I don't look at the topography on every patient, because sometimes it gets missed, right? Then that's a miss for me. I did the test. I could have diagnosed it, but I didn't actually look at the topography, even though it was part of the workup, just because I got busy. So that would be an example of a breakdown in the communication to diagnose, okay? So have a process in place for every single patient and what you're looking for and how you look for it. I love this, and I asked Melissa's with the glaucus in the back. I told her, I said, where is this thing? So it's going to be at the booth later. It is a really cool card that you can put on your autorefractor. And what I like about this is it tells you, okay, who should I be looking at that could possibly have keratoconus? Which patients should I be, flagging? And it's, cylinder greater than 2 diopters, an increase in cylinder of greater than a diopter, myopic shifts, steep K of over 47, or if you get some, sometimes you do those autorefracts and they get up the error message, right? And you're just like, what is wrong with this? Are they dry eye or what's going on? Having this card at the autorefractor is really cool, because you can have your staff look at this and say, okay, does the patient have any of these? If they do, red flag it for the doctor. It doesn't mean that the patient has keratoconus, right? It could be a number of other things, but what it does, it prevents you from not seeing it, because sometimes we just get busy and we don't, take in all the information. You can use your staff to highlight things for you and say, okay, hey, look at this patient a little closer, because, their steep K was over 47, or I'm getting really weird error messages on the autorefract. They also have another really cool card if you're concerned, or you're like, I don't know when I should actually have a patient get a corneal consult. This is another card that you can get there that will kind of guide you through. And it's not that, if I suspect keratoconus, I have to send this patient, or if I do this, it's just a guide to help you think through, okay, when should I be sending these patients on for a corneal consult and when should I not? Okay, failure to diagnose. We're going to switch gears to referrals. I've said it repeatedly, and I will keep saying it. Keratoconus is a progressive disease, just like glaucoma. that we need to monitor appropriately. So these are a couple of studies that came out. This first one's very interesting because they did this in patients who were unable to be seen at their appropriate follow-ups because of COVID. When things shut down, these patients missed their follow-ups. They saw that 100% of those patients in that 3 months that they didn't have their follow-ups progressed. Their keratoconus progressed within those months. In another study over to the right, 88% of pediatric patients with keratoconus who did not undergo cross-linking progressed within 12 months. 88% progressed within 12 months, okay? And then we've all heard of the PLEX study. And in that, 74% of patients, keratoconus patients, who were being treated with contact lenses demonstrated significantly impaired visual quality of life. That's what that VQOL is, visual quality of life, that continued to decline over 7 years. So putting your keratoconus patients in a contact lens and just monitoring them and, is not what we need to be doing. We need to dig a little deeper into these patients and make sure that we're not seeing progression. Because if you see progression, they should be referred out for corneal cross-linking earlier rather than later so that they don't progress. This is interesting. 2 studies up here. The first one they did, it was a survey study of several medical offices. And they asked them, what is your number one risk management issue? Like, where is your risk? And they came back, 53% said it's in the referrals. Do you think your referrals are your biggest risk? Like, do you think once you refer somebody to a retina specialist, glaucoma specialist, or whoever it is, do you think, oh, I'm really at risk here because of my referral? We don't typically, right? I mean, that if you surveyed, if I just thought through it, I would think, okay, but you are. And the reason you are is if you look over at the other side of the slide, the right side, a lot of the claims come from, it's really a breakdown in communication, like we said before. Breakdown in communication for the diagnosis, a breakdown in communication for the referral. And where this falls apart, it can fall apart with you and the patient, because you educated the patient, hey, I'm going to send you to this physician for this consult, and either the patient didn't understand it, the patient doesn't want to go, or the patient, didn't make the referral. So where this breaks down in your office is if you refer a patient out and they don't go to the appointment or they don't want to, and you don't follow up on it, and then they progress, guess who has liability in that? You, which is crazy. I know you think personal responsibility, right? But, and yet they do. But if you didn't document it properly and you didn't tell the patient, with your documentation that this is what you need to do, then we can have some risk there. So the referral is so important, and I'll tell you my process in just a minute. The referral is important because when you can read this bottom, see the bottom in quotation marks, that comes straight from the American Academy of Ophthalmology's preferred practice patterns for progressive keratoconus. And it will tell you that if you see progression, you need to refer the patient for corneal cross-linking so that they can maintain good vision. Because what happens, they go get the cross-linking and then they come back and they can maintain good vision with glasses and or contacts. Okay? So how do we protect ourselves? And this is just overall. I'll just tell you what I do in my practice. I get really concerned about patients that I refer out for any disease that's progressive or sight-threatening. So I have a really tight referral process to make sure that we follow it for every single patient. How we do it in my office is I generate a letter to the doctor, is basically my chart notes, right, saying this is why the patient needs the referral. My staff sends the letter and makes the appointment. I don't allow my patients to make their own appointments for anything other than cataract surgery, because unless it's, something, bad about the cataract surgery, I can imagine what that would be. But if it's something that's not sight threatening or not progressive, I'll let my patients make the appointment. But anything else, I make the appointment for them and I document it. The reason I do that is to ensure, okay, this is when the patient's appointment was supposed to happen. We actually go back and make sure that the patient kept that appointment. You can't depend on the other doctor, one, to call the patient and make the appointment themselves. That's out of my control, and I'm a control freak, so I don't like being out of control there. So in our offices, our process is we generate the letter, we call the patient with the appointment time, we document it on there, we document it in their chart, and then I have one staff person in each of my offices who's responsible for referrals. We actually have a spreadsheet saying, okay, this is the patient, this is who we referred them to, this is why we referred them, here's the appointment time, and then we look at it every week and see, okay, who was supposed to go to who when, and then if we haven't gotten notes back from the other physician, we call and see if the patient made the appointment, and if they didn't, then we start trying to get the patient back into us or to that doctor. But we know that, okay, something's going right here, yes.
So you make the appointment, you give all the information, and they don't go, but somehow it's their legal responsibility. I don't understand.
It's not.
How could you get legally in trouble?
As long as you documented it appropriately. So what I can tell you is that oftentimes our documentation of telling the patient why it's important for them to follow up, to go to this appointment is lacking. So if I put in my chart note, I told the patient that if they didn't keep this referral, they could go blind, and the patient goes blind, I told you. But often it's the documentation that gets us in trouble of, hey, you didn't tell me that, I kid you not, I had a patient this week who came in with 0.9 cups. And I said, have you never been told that you had glaucoma? I mean, I'm like shocked, right? New patient. And she says, no. And I thought, how could somebody, she's a -5 myope. I mean, she goes to the eye doctor, right? How could somebody have missed this? It's crazy. They didn't. I got her chart notes from the other doctor. It had in there glaucoma. She was supposed to come back. She never did. But in the documentation, it never really said, hey, guess what? You could go blind if you don't come back. So that's where we get ourselves in trouble. If you've documented, I told the patient, if you don't follow up with this, if you don't do this, then you have a risk of visual loss. Then, at that point, I've done my duty, right? Yeah.
Okay, so here's my next question.
Yeah.
You have EHR.
Yeah.
If you put in like a sticky note that goes for a certain diagnosis.
Yes.
Risk of blindness, patient identification of risk of blindness. So that every time you make those diagnoses, would that be legally binding, or do you have to actually type it?
I have that in my same EHR, and if it's something, if I get concerned about a patient that I'm like, they're a little squirrely about this, I type it myself just so I have it in there. I know I said this. Because sometimes, it's hard to challenge the record. If you put it in the record, but sometimes those copy forwards or the things that stay in every single patient, the sticky notes or whatever it is, sometimes, you can say, oh, did you really say it? So having a handout, like, I've got a handout for this, and this is what I'm giving to you, and this will tell you what your diagnosis is, and this is, those types of things help too. The more documentation that you can have in your record or give to the patient, the better. It's just going to protect you. And hopefully it never comes to anything, but if it does, you don't want to be the one sitting there. Okay, and then we follow up and make sure that the patient got to the visit. Like I said here, ensure the patient understands the referral and the risk of noncompliance. So, have you ever had a patient say, I don't want to go. I'm not going there, it's too far away. I have. I literally had a patient say, I don't cross that bridge. And you're like, well, you're going to go blind if you don't. That's crazy. So, if they don't want the referral, they refuse the treatment, whatever it may be, I encourage you to have an informed refusal sheet. It's basically, you can have a generic one. You can just write out, what it is, the risk. And then I like to have the patient sign it. Okay? Like if they're in the office and they're like, I'm not going there, I want to have them sign it. I put it in their chart. What if the patient won't sign it, which has happened? So I don't know, even though you're telling me that, I'm not going to sign it. Then I put patient refused to sign. And the date. You can only do so much, but at least I tried. Okay. So what if a patient doesn't go to the referral? You did all of this, you made the appointment, and the patient didn't go, or the patient didn't come back. So say you're suspicious for somebody with keratoconus, and you're like, I think they may be progressing. I want to see them back in a few months. You schedule them back in a few months to check it, and they miss the appointment. So what do you do then? For us, certified mail is my last resort. I try 3 attempts to get the patient on the phone and in the office, and I document each time I do that. Mrs. Jones, you missed your appointment with this doctor or with us, whichever it may be. We're concerned about your vision. Please call us, right? Or whatever it is. I document each time we call them. If we do 3 attempts, we can't get the patient, then I send a certified letter, return receipt, because you want to make sure that the patient got it. Put the return receipt into the letter and the return receipt into the patient's record. So, and I'll tell you, we had a patient several years ago who showed up, who lost vision in one eye with glaucoma, and he told us straight up that he didn't go back for 10 years. And he said, but the doctor didn't tell me I needed to go back. He sued the doctor, and we got wrapped up in it because, it was a new patient to us. It wasn't anything. But still, he claimed that the doctor never told him that he needed to come back, and never told him that it was, a progressive disease or something that he needed to treat. So it does happen. Okay, so in the referral process, we have a duty and we have some liability there if we don't follow the appropriate processes. But typically, when we refer a patient to a doctor, we don't have much liability because we usually refer them to somebody who's, board certified. They're provided the current standard of treatment, right? Not the case in corneal cross-linking. And so I want to take just a minute to explain to you what these 3 things are. So iLink corneal cross-linking is the only FDA-approved corneal cross-linking treatment for keratoconus and corneal ectasia, okay? When a physician uses iLink for those 2 diagnoses, that's on label, okay? If, for example, the physician used iLink treatment for something other than those 2 diagnoses, that would be off-label because you have something that has been studied, it's shown effective and safe, but I'm using that treatment for something that wasn't in the study itself, okay? That would be off-label. Yes?
Do we have any liability if we make an appropriate referral for keratoconus that's progressive and we refer to an ophthalmologist who's black box off-label?
Yes. Yes. So and that's not off-label, it is not approved. Not approved because
liability if that's what they're doing.
You could, because the referral it's called negligent referral. You have to do your homework to ensure that whoever you're referring to is providing the appropriate standard of care treatment. So I encourage you, and they're going to hold CE for a little bit, so you don't have to rush out. I encourage you to, the slides are very slow. There is a website that you can use to research physicians who are using iLink, okay? And I encourage you, I look on that website, call them, go into their office, make sure you like what they're doing, and it gives you an opportunity to see the procedure so then you can educate patients on it. We have studies that show that physicians who are not using iLink, who are using non-FDA approved corneal cross-linking, it's inferior. And patients who have had that type of epi on, is what it's called, cross-linking, have actually had to have it redone with epi off. So not only is it not FDA approved, it's not as good. We know that. So when you make a referral, make sure that you're actually referring to someone who's using standard of care treatment. Because if you don't, you do have some risk there. And then this is the website that I was discussing. Any questions on that? Oh, and one more thing I wanted to tell you. So when you refer for iLink, good, patients getting FDA-approved treatment that we know is safe and effective. But also, a lot of the time, it's going to be covered by insurance. So the other physicians, other ophthalmologists who are using non-FDA-approved cross-linking, it's not covered by insurance because it's not FDA-approved. So your patients are going to be paying out of pocket. So if your patient, for some reason says, oh, I saw this doctor and they wanted to charge me this much, you need to have a red flag in your head of, wait a minute, that doesn't sound right. Because if it's a progressive keratoconus, it should be most of the time covered by their insurance. Okay? So takeaways here. 1, make sure you have a process that you can diagnose these patients earlier rather than later. And 2, if you see progression, refer them, but refer them to the right people. If you have questions, you can always reach out to Glaukos because they work very closely with a lot of these physicians. Any questions? That's my talk, but I'll stay around for questions.